a discussion of the two studies that you've just heard, which will be given by Dr. Laurie Pierce from the University of Michigan. Dr. Pierce.
Yeah, I don't need that. And so how do I advance the slides?
Left click.
Left click.
Well, I appreciate the opportunity to discuss these very interesting abstracts. How do I? And my disclosure? Well, the first abstract looked at race and outcomes among patients enrolled in the landmark responder trial, which demonstrated, of course, a benefit for chemotherapy in the premenopausal cohort. And in the present analysis, based on race, some of the key findings was that the recurrence score distribution was similar among all racial groups, that there was a lower 5-year invasive disease-free survival and distant disease-free survival for Black women compared to other racial and ethnic groups. And after adjusting for recurrence score and treatment arm, Blacks did significantly worse than whites for invasive disease-free survival, even though part of that was due to BMI. And there was no significant difference in treatment effects between Blacks and whites, but there was limited sample size and power to make conclusions regarding the chemotherapy benefit. And so when you see differences for groups, you begin to look at factors that perhaps contributed to the less favorable outcome, in this case for Black women compared to white women. And one thing that perhaps should be considered is the dose intensity of chemotherapy. And I called some of the important work from Dr. Dawn Hirschman and her colleagues that have looked at this. There is a common form of neutropenia called ethnic benign neutropenia that is very common in Black patients. And it is caused by the gene that is associated with the Duffy null trait. And while it is benign, it can have consequences, and it can perhaps affect the intensity of chemotherapy. You look at Dr. Hirschman's work, and look at the white blood cell counts for whites versus Blacks, and the Blacks is the shaded graph. And you see, if you look at the baseline counts, they are much lower for Black patients, and certainly the counts at the end of treatment are lower. And that then translated into a longer duration of treatment for Black patients. So duration of adjuvant chemotherapy by race was longer for Black patients, and perhaps that could have impacted dose intensity for the Black patients in the study. And as the presenter very nicely noted, we have to look at endocrine therapy adherence. And the adherence was similar in the first year, but we have to look at the adherence over time. And again, I looked to some of the amazing work from Dr. Hirschman and colleagues that looked at the racial difference in adherence to hormonal therapy. And you see that, yes, there was a lower adherence for Black patients, but if you look closely, it really related to finances, that if you look at those who had a high net worth, there was no difference. It's in the low net worth, and so it is the financial implications for therapy that made a difference in terms of compliance. And so factors that must be considered, and it was discussed very nicely by the presenter, is that we have to look at social determinants of health. We know that they significantly impact the outcome for our patients. You look at economic stability, you look at neighborhood and physical environment, education, food, community and social context, and healthcare system. They will dramatically impact the outcome for our patients. And we have to systematically collect these data. We don't have a good way of doing that, and we need to do that, including for clinical trials. And so we also must have adequate representation of racial and ethnic groups in our clinical trials. If you look at this study, we have over 5,000 patients were eligible in the trial, 4,400 women accepted treatment of the assignment, and a little over 4,000 were included in the current analysis. And if you look at the race and ethnicity, 70% of the patients in the study were white. It agrees closely with the 2021 census data in the U.S. You look at Hispanics, 15.1% were Hispanic, and that number was enriched because of the collaboration with the Spanish Research Group on breast cancer, so 15.1% versus just under 19% in the U.S. population. You see a slight over-representation for Asians in this trial compared to the U.S. population. For the Native American Pacific Islanders, 0.8% in the trial compared to 1.6%, and the numbers were so low, as we heard, they could not be included in the survival analysis. And then if you look at the black patients, 6.1% in the trial were black compared to 13.6% in the U.S. population. And the numbers were so small, were not adequate, so that the authors could not look at the impact of chemotherapy, which I think was a primary goal. So this is a reminder, it's not just the RxPonder trial. This is pretty indicative of what we have in our breast cancer trials. We need to do a better job of placing patients on study. So simply put, we need more patients of color as participants in clinical trials. And we know that there are barriers to putting patients on study, and we talked a little bit about that in the panel. So from the clinician side of things, limited physician communication with patients regarding patient enrollment. Well, we need to have teams. We need to be able to have teams so that it's not just the physician, but it's also other members of the team that can communicate to patients about the importance of clinical trials. We know there is physician bias. We all have biases. We need to acknowledge those biases. We need to mitigate those biases so they do not interfere with our ability to interact with our patients. We all have limited time and resources, and we need to work with our administrative teams so that they understand the importance of the time that it takes to put patients on trial, so that we have that flexibility to increase our discussions with patients. We need to have greater knowledge of the trials that are available to make sure that the populations that we treat, we have the appropriate trials for those individuals. And we need to reach out to our learners to increase workforce diversity by emphasizing how rewarding careers are in oncology. And we know that there are barriers from a patient perspective as well. And for the interest of time, I'll go right to that last bullet, distrust. Without a doubt, there are certain populations that have a distrust in the medical field, and this distrust is not without good reason. So we need to spend the time, we need to take the time to have dialogues with patients so they feel more comfortable with their caregivers. But despite the trust issues, when asked, patients will enroll on cancer clinical trials at about the same rate, whether they are white, black, Hispanic, or Asian. This is a very important analysis done by Dr. Joe Unger that looked at, when offered to participate, a systematic review and meta-analysis of patient agreement to participate in clinical cancer trials. And you see 56% of white patients, 60% of black patients, 67% Hispanic, and 63.6% Asian. So we need to remember to ask our patients to participate in clinical trials. Okay, the next abstract looked at racial disparity in tumor microenvironment and outcomes in residual breast cancer treated with neoadjuvant chemotherapy. And as background, and you heard covered very nicely, tumor microenvironment and metastasis, TMEM, consists of a direct contact between macrophages, endothelial cells, and tumor cells. And in previous work from this group, TMEM score has been shown to correlate with the risk of distant metastasis in ER-positive, HER2-negative breast cancers. And also from this group, largely based on mouse models, it has been suggested that neoadjuvant chemotherapy may lead to pro-metastatic changes in the tumor microenvironment. So then in the current abstract, it demonstrated a higher TMEM score, doorway score, in black patients in the entire cohort and in the ER-positive, HER2-negative subtype. And it showed a significantly higher rate of distant metastasis among the black patients compared to the white patients on that study. And the conclusions in the abstract was racial disparity in outcome may be due to a more pronounced pro-metastatic response to chemotherapy in black patients with ER-positive, HER2-negative disease. So the authors suggest that disparities in breast cancer outcomes observed in black women relative to white women could be attributed in part to greater changes in the tumor microenvironment in black women. I think that's very provocative, and it's certainly very possible. But why? what is there about the black race that would lead to this result? We are a very diverse race. We are very heterogeneous. And some of the suggestions from the audience looked at other factors. Why would we see this result? But I think that the bigger clinical question is this due to neoadjuvant chemotherapy? Do these data suggest a pro-metastatic effect of neoadjuvant chemotherapy, which is more pronounced in black women? So prior work by this group had suggested that they looked at MEM prior to chemo neoadjuvant and then after, and they saw a difference. That could not be done in this study because there was no baseline MEM data. So it's unclear whether there was a change with neoadjuvant. But I think the key part is if we think that neoadjuvant chemotherapy promotes metastasis, then there should be an inferior outcome compared to adjuvant chemotherapy, but that's not what we see. Well-powered randomized trials show equivalent outcomes with neoadjuvant chemotherapy as well as with adjuvant. So if you looked at the Early Breast Cancers Trials Collaborative Group, the curves are almost superimposable. Distant recurrence at any time, breast cancer mortality, any death crude rates, they are superimposable. So while I think these data are very provocative, I certainly wouldn't want black women or any women who need neoadjuvant therapy to be discouraged because of these data, because we need these data to be rigorously tested clinically. So I look forward to the clinical trials that will test this question and can really give us more information about this very interesting hypothesis. So here we have two abstracts that have observed a worse outcome for black women. But we have to consider that there is an immense heterogeneity within races. And we also have to think about the arbitrariness of race. An example of the extreme arbitrariness of race is the historical system of blood quantum. And with blood quantum, if you had 1 drop of blood of African ancestry, you were considered black. But it's the exact opposite for Native Americans. So Native Americans had to actually prove they had a specific measurement of Indian blood in order to qualify for the treaty obligations promised to tribal members. Quite simply, race is a social construct, and it was based on power and greed. So with that backdrop, how should we, as researchers, analyze outcomes by race? Should we analyze outcomes by race? Well, I think it is very important to do this. I think it's very important to consider race. But we have to do so very thoughtfully so that we don't perpetuate some of the concepts that we're actually trying to disprove. Without a doubt, biology, ancestry is so very important, but we also have to dig deeper to understand and address the hidden factors, social determinants of health, that contribute disparities attributed to race. I think this is our collective responsibility, and I believe the onus is on us to do so. Thank you.
Thank you, Dr. Pierce, for that outstanding call to action.